This PowerPoint is going to review periodic leg movements of sleep. We're going to identify the symptoms of PLMS and RLS, identify how PLMS RLS is diagnosed, identify how PLMS RLS is treated, and differentiate between PLMS and RLS and normal movements. Let's go on. Normal movements in sleep. Typically, normal movements are isolated movements of the arms and legs. These are not considered PLMS or RLS. They may occur 50 to 100 times in a 7 to 8 hour sleep period and are still considered normal. Axial changes of the body may occur. This is common 5 to 7 times in the average night. Sometimes they cluster 10 minutes before or after REM sleep. Fascicultations, these are muscle twitches. These are common during REM sleep. Generalized movements can be exacerbated by pain, discomfort, psychological interferences, environmental disturbances, and a variety of other sleep disorders, including sleep apnea. Let's go on. Periodic leg movements of sleep. The definition is a muscular skeleton condition where there's a burst of EMG activity in the anterior tibialis muscle for 0.5 seconds, but not longer than 5 seconds. These should be greater than 25% of the amplitude of the baseline signal seen during biocalibrations. 4 consecutive movements with intermovement intervals of 40 to 90 seconds is required. Okay, so what all that technical stuff means is that you put electrodes on their front of their shin. That's called the anterior tibialis muscle there. You'll find that muscle. You have your electrodes there. During your biocalibration, you'll have them move that, and you will get a baseline that you will compare all other leg movements to. So now, once your patient is asleep, if they have a very short burst of muscle activity in that lead, so it has to be longer than a half a second, but it can't be longer than 5 seconds, then you also compare how big or how much of a mess that one wave makes when they do that to what they did before they went to sleep during your biocal. Now, they have to have 4 consecutive movements just like that in order for it to be considered PLMS. And it has to be within 90 seconds. So if you had one movement and then 5 minutes later you had another movement and then 5 minutes later you had another one, if that happened 4 times, that does not meet the PLMS criteria. The 4 movements, one has to occur within 90 seconds of each other. Okay? Measurement techniques. Again, the electrode placement is on the most prominent portion of the anterior tibialis muscle. Occurrence. PLMS occur primarily in the first half of the night. So typically they occur in stage 2 sleep. You see an increase in frequency with each decade of life. So it's very rare in kids less than 10 years old and common in the elderly or those greater than 60 years old. So you see it occur more as people get older. The clinical relevance, equal to or greater than 5 PLMS runs per hour is considered abnormal. PLMS are clinically relevant when they cause an arousal, that's a 3-second or longer shift in the brain activity, and have occurred within 2 seconds before or after the movement. So in order for a limb movement to have said to have caused an arousal, the limb movement has to occur within 2 seconds of an arousal, and the arousal can occur before the movement or it can occur after the movement. And if that occurs, if they're starting to wake a person up, then they are clinically relevant. Typically, when we are talking about clinically relevant, then we're considering that it needs to be treated. If it's abnormal but not clinically relevant, then they may not treat the PLMS. In elderly, normal PLMS may be as high as 15 per hour. Let's go on. Now, restless leg syndrome is different from PLMS. Let's look at the definition. The definition is a neurological condition where the legs have an uncomfortable or crawling sensation that may or may not be relieved with stretching or walking, and that occurs during periods of inactivity or rest, and are worse in the evening or nighttime. Take note, RLS sufferers often have arousals due to isolated movements, not PLMS. 80% of those with RLS will have some degree of PLMS. When PLMS occurs with RLS, There's relatively few limb movements that actually cause arousals, but often the isolated movements will cause the arousals. Relatively few people with PLMS also have RLS. So if you have RLS, there's a high likelihood to have PLMS, but if you have PLMS, there is not a high likelihood to have restless legs as well. Is that clear as mud, or? Okay, let's. Diagnosing RLS can only be made off an interview of a patient. What you will find is an urge to move the legs that is often accompanied by an uncomfortable sensation. The urge to move worsens when the person is at rest. Upon movement, the urge is at least temporarily relieved, and the urge to move worsens later in the day, typically in the evening or around bedtime. So, important note here, diagnosis for RLS is made off an interview. Diagnosis of PLMS is made off a polysomnogram. Let's go on to our next slide. The occurrence of restless leg syndrome, most cases are primary, meaning genetic in origin, so other family members have it too. Women are more affected than men, and symptoms often start before 30 years of age. And then remember, this increases with each decade of life, so it only gets worse from there. Secondary occurrences, this is when RLS develops as a secondary condition. Sometimes it can occur with pregnancy or with renal failure or iron deficiency. That's the most common secondary cause, actually, is iron deficiency. You can check the serum ferritin levels to rule out or to confirm this, and these are usually much easier treated, at least the iron deficiency is. Let's go on. Treatment. Dopaminergics. Some examples are Requip or levodopa. These reduce the number of periodic limb movements and treats restless leg syndrome. The long-term risks are augmentation. This is worsening of the symptoms. People report needing increased doses because the symptoms are moving to other parts of the body or they appear earlier in the day. Some of the side effects include nausea, vomiting, muscle joint achiness, headaches, and lightheadedness. Other possibilities to treat, though, are Mirapex, Permax, and Neurontin. All of these are still being studied, but they have been found useful in certain groups of people. Clonazepam or Klonopin is commonly used. This used to be the first-line treatment. However, it has some potentially addictive properties, so it's only reserved for when dopaminergics do not work. So dopaminergics have become the first-line treatment. Let's go on to our next slide.